we'll have the next speaker. Important topic, ECG in all of our life. So the topic I suggested him was ECG Made Easy, which is very popular by Dr. Mishra. So now our next speaker has come. Let me ask Ganesh to
So before going to that, shall I answer your questions, sir? So they have proved that the cross reactivity or immunity for 6A and 6B is not to the level of preventing the disease. So it's ideally better to have the particular serotype which is going to be the cause of the infection. That's what they have proved. Okay. And they have also promised that the PCV20 will not cause extra cost than the 13. Even though they have increased the serotypes, they have promised that they will not increase the cost of it. That's what last meeting I asked, they promised that there won't be, 7 to 13 you never change the price. Similarly from 13 to 20 also you are not going to change the price.
better to tell it in a meeting.
Yeah.
So that it is open.
Yeah. Thank you. And I'm really happy to introduce Dr. Sundar, whom I have been knowing from his college days, from 1996 probably in Madras Medical College. And he is a very active clinician as well as academician. He is a practicing interventional cardiologist, MD, DNB cardio, FNB and FSCAI. And is the director of Cardiac Cath Lab, Interventional Cardiology Center in Nandanam. And on receiving Dr. Sundar, we can never forget his father, the famous and popular diabetologist Dr. Hariharan, who was my teacher. So wonderful, we are very happy to see you. Mother microbiologist. So he is from a very heritable family and very active person. I think he is the third speech he is going to deliver today. So much of activities, he is engaged in all the academic activities, and I am very happy to see him. But the topic which we are going to face today is a very wonderful topic for all our practitioners. Even though we have been reading a lot of ECGs, that particular ECG may be a big puzzle for us. So as a family practitioner, we are always wondering how to read the ECG, how to interpret the ECG, how are we going to proceed with the individual patient. So here is Dr. Sundar, who is going to make this very, very easy for us. That's the reason we have coined the topic named as ECG Made ECG Made Easy for the practitioners. So over to Dr. Sundar.
Thank you, sir. Slide change, everyone.
Do point wrong.
Right. Okay. Thank you, Dr. Ganesh. Thank you, Impai. Thank you, Dr. Sachidanandam, Dr. Kailash, for this opportunity. In fact, this is a very favorite topic of mine. I don't know how many times I've had this session done to a lot of postgraduates and a lot of students. And I'm extremely honored to do this talk in front of somebody who taught me depolarization, repolarization, Dr. Ganesh. So, the ECG or basics and the depolarization, repolarization. So, I am just remembering the days in Madras Medical College when we used to attend the classes on depolarization, repolarization. So, the basics started from you, sir. Thank you so much. So, and ECG is always a puzzle. When we were undergraduates and all of us, ECG has always been a mystery. Whenever we are given an ECG, we always tremble. We always are fearful about whether we read the ECG properly or not, etc., etc. So, in fact, the ECG sessions in MMC as well as in German Hall, Dr. KP Mishra's sessions used to be packed. In fact, the ECG sessions will be so much packed that people will be standing outside to listen to KP Mishra's talk on ECG. So, that used to be the enthusiasm in ECG. I wouldn't say the enthusiasm on ECG has come down, but the problem of specialization had made the necessity of ECG in sort of MBBS, MD levels drop. Because everything now becomes specialized, that people tend to refer cases. So I think the priority of my talk today is to diagnose the cases at the primary physician level. See, I think that is the key factor in today's world, because many times what we see is patients get diagnosed late because they get an ECG done in one place and that ECG doesn't get interpreted, and they go home, keep the ECG in their pocket, come to a consultant 2 days later with an infarction. So many delays happen because we are scared of interpreting an ECG. We are scared of telling that this is the problem in the ECG and referring, and it becomes a negative, or rather a vicious cycle, and that creates a lot of trouble. So the independent practitioners, the primary physicians, I think if you want to know one single investigation which is going to really change the course of anybody with a problem, is an ECG. Just 150 rupees, 100 rupees, one small slip of paper, it is going to change the fate of somebody. So I don't think any other investigation, it is an extension of the bedside. It's an extension of your clinical practice. It should be. Everybody should possess an ECG machine, just like you have a glucometer. So that is the importance of ECG we need to give, because that importance sort of, though the ECG is there, we don't give that importance compared to what we were giving 20 years ago. So I always call ECG the big boss of cardiology. It is the big boss. Even after 200 years, I don't think any investigation in cardiology, whatever comes, AI or even beyond that, it is going to replace a ECG. ECG is ECG. Even today, acute myocardial infarction is diagnosed only by ECG. You cannot diagnose by anything else. If you want to thrombolize, even now, the guideline is ST elevation. There is nothing else. So even with all the technologies, you don't have any other way of diagnosing an acute MI than anything else. So I can talk a whole day about ECG, especially with the slides given to me, but I will restrict for half an hour. Dr. Raghu sir, please, whenever, I don't want to end with the bore. I want to start whenever you get bored, so please stop me. So I'll just quickly zip through, because this is going to be a very, very practical session. So this is not for a botanist, because we are all gardeners here. Because we are all clinical practitioners, we are not research people. So we are all going into the battlefield every day, treating patients. So I'm not going into a lot of theory about electrophysiology, ECG in depth and things like that. But I'm going to just zip through some of the basics which you need to know. Yeah. So this all of us are aware of, the conduction system. You have the SA node of the heart here. You have the AV node here. You have the bundle of His. Then you have the right bundle, the left bundle, the Purkinje fibers. You have between SA and AV node, you have these conductions, internodal conduction, and from the SA node, which is on the right atrium, you have fibers going into the left atrium, which are called the Bachmann's bundle. So this is basically the physiology, the conduction system, which we are all taught right from MBBS days. And each node, from SA to AV node to the bundles till the ventricular Purkinje, have their own innate automaticity, which is the so-called the pacemaker rhythm. SA node from 60, AV junction 40, and Purkinje at around 20 to 40. We have basically only two types of ECGs. One is a 12-lead ECG, which we all record day in and day out. And the other one is a rhythm strip, which provides information only about one lead. Now ECG leads, all of us are aware of standard limb leads, augmented limb leads, chest leads, and modified chest leads. Again, I'm not going to go into detail about each one. We are only going to concentrate on standard limb leads, augmented limb leads, and chest leads. Standard limb leads are nothing but bipolar limb leads. Standard limb lead are lead 1, lead 2, and lead 3. Lead 1 means why is it bipolar? Because it gets you the electrical difference between right arm and left arm. Lead 2, right arm and left leg. Lead 3, left arm and left leg. So 2 poles, so bipolar. That is what is the 3 standard limb leads. Lead 1, lead 2, lead 3. Then the next is the augmented limb leads. Augmented limb leads are nothing but AVR, AVL, and AVF. A stands for augmented, and letters R, L, and F stand for positive electrode position. So AVR is right side. They measure electrical activity between one limb and single electrode. So right limb and that electrode. AVL, left limb and that electrode. Left leg is left foot and that electrode. So these are all unipolar leads, augmented unipolar leads. So AVR, AVL, AVF, lead 1, lead 2, lead 3. Then comes your chest leads. I'm sorry, I have to be fast because of time limits. Chest leads, as you all know, is V1 to V6. We do have V7, V8, V9, V10, V11, V12 till the posterior fold, but that is not important in clinical practice. We know only V1 to V6. So V1, V2. The fourth intercostal space on the right side of the sternum is V1. The fourth intercostal space on the left side of the sternum is V2. Then jump to V4. V4 is the left fifth intercostal space at the mid clavicular line, and between V2 and V4 is the V3. And then again jump to V6. It is in the mid axillary line at the level of V4, and between V4 and V6 is your V5. And all these leads are important because this is going to represent septum of the heart. V2 is septum, V3 is anterior, V4 is anterior, V5 is lateral, V6 is lateral. This is septal plane of the heart, anterior LV, lateral wall of the LV. So that is how the representation goes. So you have the standard limb leads 1, 2, 3. Then you have the augmented limb leads AVR, AVL, AVF. Then you have the 6 chest leads. These are the 12 leads. So this actually comprises of the electrical system of the heart, with which we can play around with all the diagnosis, right from ischemia, arrhythmia, brady, tachy, etc., electrolyte imbalance, everything. All these things can be diagnosed in one piece of paper, 100 rupees. Now the waveforms. I'll just zip through it and I'll be very, very crisp on that. You have the waveforms of the ECG. This is your standard P wave, an upright wave. Then you have a QRS. Q is the first negative deflection. Then you have a R. Then you have a S, which is the second negative. Then you have a ST segment. Then you have an upright T wave. Then you have a U wave. Very, very simple. P wave stands for atrial depolarization. You have the expert here, Dr. Ganesh, because he taught me this. I still remember physiology hall. Atrial depolarization. The atria depolarizes. Then you have the QRS, which is the ventricular depolarization. So you have, after the atrium getting depolarized, ventricle depolarizes. Then you have the quiet segment, where there is no electrical activity, quiet segment of the heart. Then you have the ventricular repolarization, RE. Then you have U, which is the late ventricular repolarization. So you can just leave this. This is for a very rare cause. So atrial D, then ventricular depolarization, then you have the ventricular repolarization. And you have to know two terms in ECG here, intervals and segments. Interval number one is PR interval. Whenever you say an interval has a wave, then only it is an interval. An interval has a wave. PR interval has a P wave. So PR interval starts with the beginning of the P to the beginning of the QRS. So it has a wave, that is why it is an interval. Whereas if you see a segment, ST segment, which is a very important segment because ellame ST segment, ST elevation, ST depression. So ST segment doesn't have a wave. It is from the end of the S wave where it contacts the isoelectric line of the ECG, which is the J point, to the beginning of the T. So it is a straight line. There is no wave here. That is why it is a segment. Segment doesn't have a wave, whereas an interval has a wave. That is the difference. So you have the ST segment here. So you have a PR interval, then you have a ST segment. In between you have a QRS interval, where it has a wave, another QRS interval. That is why it is an interval. Beginning of the Q, enclosing the R, ending of the S vertical, it is the QRS interval. So you have the PR interval, you have the QRS interval, you have the ST segment. These three, if you know, you have mastered ECG. That's it. So what does the PR interval tell? P is depolarization. So PR interval is nothing but the time taken for the impulse from the SA node, because P wave varudhanale SA node is getting activated. From the SA node to the ventricle or the AV node accordingly. So PR interval is the time taken for the impulse to travel from SA node to the AV node when the ventricle starts to depolarize. So any disease of the PR interval will denote that there is a disease in the conduction system. There is a delay. QRS interval denotes ventricular depolarization. So if it is becoming prolonged, you know there is a disease in the ventricular muscle. So muscle is diseased, muscle is weak, LV dysfunction, QRS broadens. So that is the thing. ST segment, the most important segment, denotes all the ischemia, injury, electrolyte issues, everything comes into the ST segment, which is usually the quiet segment. It is always quiet. So whenever that quiet segments get disturbed, sadhu marindal marida. So anytime that means something wrong is happening. Then the T wave. which I told you is the ventricular repolarization. So, and then you have one more, which is the QT interval from beginning of Q to the end of the T, which is again an important interval, but not for clinical importance in this audience. So, we need to know PR interval, QRS interval, and ST segment. These are the three important points which I wanted to tell. So, this I have already spoken to you. And ECG grid. This is extremely important because when you read an ECG, you need to know the grid. Very simple, very easy to understand the grid. ECG always has small squares, big squares. So, this is one big square which has 1, 2, 3, 4, 5, 5 small squares in x-axis, 5 in y. So, 5 into 5, 25. So, 5 small squares. Each small square in x-axis is in time, in seconds, or rather it is in 0.04 second is one small square. So 5 into 0.04 is 0.2 second is one big square in x-axis. In y-axis it is in voltage. It can either be in voltage or millimeter. It is convertible. So one small square height is equal to 1 millimeter or 0.1 millivolt. 0.1 millivolt. That is why we say ST elevation 1 millimeter. ST depression 1 millimeter. Sir, how many ST elevation? 3 millimeter ST elevation. 3 millimeter ST depression. That is because one small square in y-axis is 1 millimeter, which is equal to 0.1 millivolt. So that means 5 millimeter is equal to 0.5 millivolt, which is a big square. So when you want to quote it as a big square, which comprises of 5 small squares, in x-axis it is 0.2 second, y-axis it is 5 millimeter or 0.5 millivolt, or one small square is 0.04 second, one small square in y-axis is 0.1 millivolt or 1 millimeter. Very easy to understand, very easy to memorize. This is important because I'll come to the later part of my talk why this is important. This I have spoken to you about PR interval. That is why I spoke to you all those things in one slide itself. This also I spoke to you about, and this we will see some clinical discussion at the next part of my talk. This also you will have. Now coming to how to interpret an ECG. These are the 5 important steps. First you need to, from a ECG, you need to determine the rate. Number 2, you need to determine the rhythm. You need to evaluate the P wave, evaluate the PR interval, evaluate the QRS, and then the ST, obviously. So these are the various things you need to see. This is why this so-called x-axis, y-axis is important. Because first of all, we need to take an ECG ourselves. In cardiology, when we join, first thing they will do is we need to take the ECG. We should not depend on somebody else. When we went into intervention, first thing we have to do is we have to pull the gantry in the cath lab, what the technician do. Because we should never depend on the technician or the staff nurse for certain things. Because most of the times they will make mistakes. Most common mistake what we see in ECG is with regards to the speed and standardization. That is why these two numbers are very, very important. The ECG should always be in a speed of 25 millimeter per second. ECG paper anga keela irukum 25 millimeter per second, and standardization should be 1 millivolt is equal to 10 millimeter, which I spoke to you about. Unless this is right, your interpretation of ECG will be absolutely wrong. Because if you have a speed which is say 50 millimeter per second, then everything will look like bradycardia. So there have been references where sir, bradycardia patient needs pacemaker. Karsila pathana keela vandu standardization will be wrong. Adhe mari the standardization on the y-axis if it is wrong, everything will look like left ventricular hypertrophy, tall R waves or very small R wave if the standardization is upside down. So this is very, very important when we take an ECG. That is why you need to train your staffs to take proper ECG, because otherwise we will go wrong in interpretation. That is why this is important. Once we have done a proper ECG, then how to calculate the rate. This is very, very important. How to calculate the rate in the ECG. Simple. Rule of 300. Identify the QRS complex. Count the number of large boxes between one QRS and the other. Divide 300 by this number. The resultant number is the heart rate. So if you have 5 large squares, heart rate is 60. 300 plus by 5. If you have 4, 300 by 4. If you have 3, 300 by 3. If you have 2, 300 by 2. That is how you calculate the rate. For example, in this, Number of large boxes between one QRS wave and the other one is 6. So 300 by 6 is 50 beats per minute. So you can use this as an example, or you can even calculate number of small boxes also. If you calculate number of small boxes, then it is 1500 by number of small boxes. If it is large box, it is going to be 300 by number of large boxes. Simple. Now comes the question, how will you calculate when there is atrial fibrillation? When there is atrial fibrillation, because irregularly irregular, how do you calculate? Then comes the 6-second rule. You take number of R waves, R, 1, 2, 3, 4, 5, 7. 7 R waves are there. 6 seconds plus 7 R waves. So in 60 seconds into 10, 70. 70 is your heart rate. So if you have irregular beats, atrial fibrillation, atrial PVCs, ventricular PVCs, then what you do, take the number of R waves in a 6-second strip and then multiply it by 10. So you get a heart rate. So this is the first thing you have to do in the ECG. So whenever you see an ECG, first see the standardization. 25 millimeter per second, then only go into interpretation. First see the standardization, then go to the heart rate. Once you do the heart rate, then comes the most complicated thing, which is the axis. Axis is a highly complicated thing. If you go into the standard textbooks of ECG, all of us will get completely confused. We will not sleep. That complicated is the axis. So let us not make it so complicated. Because in clinical practice, that is why I said we are all gardeners, we are not botanists. So in clinical practice, all we need to know about axis is whether it is normal axis, whether it is a right axis, whether it is a left axis, or whether it is northwest or indeterminate axis. Why is it important? If it is normal axis, that means it is okay, chalo, normal. If it is right axis, that means the heart is, the whole electrical conduit or axis of the heart is tilted to the right. That means there is something which is straining the right side of the heart, right ventricular hypertrophy, right ventricular hypertension, pulmonary hypertension, so on and so forth. If it is a left axis, that means the whole thing is happening on the left side. Something is straining the left side of the heart, so much so that the electrical axis is shifted to the left. Left ventricular hypertrophy, left ventricle dilatation, left ventricular dysfunction, LV dysfunction, so on and so forth. So for that simple practical reason, axis is important. Why northwest is important or extreme axis? Because in northwest axis, in those days KP Mishra used to say, if you have a northwest axis, that means the patient is looking upwards. That's what he used to say. Patient is looking upwards. That means he is going to die. So northwest axis always means very severe condition. Maybe a very severe end stage cardiomyopathy is the northwest axis. So simple to see the axis. Normal axis, just see lead 1 and AVF. 2 leads, 1 AVF. If both are upright, it is normal axis. That means the axis is between 0 and 90. Then coming to left axis. Lead 1 positive, lead AVF negative. That means left axis. Then coming to right. Lead 1 negative, lead AVF positive. Right axis. How I remember is, right axis means rightward. Both are looking towards each other. Lead 1 and lead AVF are looking towards each other. Shake hands, Mari. So, right. Left axis, both are looking away from each other. Normal axis, both are upright. Extreme axis is, both should look away from each other, but in a different direction. This is negative, this is negative. Or, you understand? So, that is extreme axis, northwest axis. This is very, very dangerous. This is left-sided disease. This is right-sided disease. This is normal. This is how you, in brief, identify the axis of the heart. Now coming to the normal sinus rhythm, what you all should know in normal sinus rhythm. This is how you identify. So we spoke about, first you need to identify the standardization, then the rate, then the axis. So standardization, rate, axis. These three are the first three things before you delve into the ECG. Then you have to see P wave, okay, regular rhythm. First and foremost characteristics of normal sinus rhythm, whether it is regular. Okay, 1, 2, 3, 4. So each QRS, between each QRS, the gap is the same. That means it is a regular rhythm. Rate normal, yes, rate is normal. Looking around 60 to 9, maybe around 70, 80 around. Then a P wave for every QRS complex, all P waves similar in size and shape. So yes, P is wedded to this QRS, P wedded to this QRS, P wedded to this QRS. All P waves are of equal size and shape, no abnormality, very good. All QRS complex similar in size and shape, yes, 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 yes. Normal PR interval, yes. Normal QT interval, normal QRS interval, upright T wave, irukku, avladhaan. This is a normal ECG, simple. So you just incorporate whatever we have learned in the last 10 minutes into this. It will satisfy all your diagnosis for a normal ECG. This is a normal ECG. Of course, there are some T-wave inversions which we'll talk about later. This is what you have to understand. Standardization, rate, then your axis, then the arrangement of this beautiful thing PQRST, you get a diagnosis. Now, I have finished my introduction of ECG. I have completed my theory. Henceforth, no theory. I am going to dwell on certain practical points. If somebody wants to volunteer, they can volunteer. Otherwise, we will just carry on. I know Dr. Raghu will be raring to go with the ECGs. He is an extremely interested person in ECGs. So I will just discuss certain scenarios in ECGs, common scenarios which you will be addressing in daily practice. Most importantly, ischemias. This is a 50-year-old male, chest discomfort for 3 hours. Okay, chest discomfort for 3 hours. This is the ECG, 3 hours chest discomfort. Your diagnosis? Perfect. Inferior wall MI with reciprocal changes. So why inferior wall MI? Because lead 2, lead 3, lead AVF. Perfect. Shows ST elevation. And what is reciprocal changes? When you have ST elevation in inferior leads, you get ST depression in your anterior lead. V2, most importantly. V1 is less varum, but V2 is most commonly the lead in which we get a reciprocal change. So this is an inferior wall MI with a reciprocal changes. Culprit vessel usually is the beautiful. So we have cardiologist in the group. So ECG changes in MI. We need to know some of the important points in ECG changes in MI. How to locate an MI based on the ECG change. This is a common question, but we need to keep on updating ourselves. Very, very simple. There are 3 coronary arteries. LAD, LCX and RCA. These are the 3 coronary arteries we have. With the ECG, we can easily tell which coronary artery is involved in an infarct. All of us know infarction means ST elevation. Ischemia is ST depression. So you need to have ST elevation in some of the leads to say that, okay, chalo, this is the artery which is involved. In a LAD infarct, left anterior descending artery, because that is the most important artery. In a LAD artery, the commonest leads which show ST elevation is V2, V3, V4. Sometimes if it is an extensive anterior wall MI, V5, V6 also. So you have extensive ST elevation from V2 to V6 if it is a LAD, left anterior descending artery, because it is an anterior wall. We spoke about the chest leads. Everything is in the chest. So anterior wall is in the over the chest. So that is the lead which you have the maximum ST elevation. Then coming to the circumflex artery, second artery, circumflex. Circumflex is always a subtle artery which, when it is involved, suddenly circumflex is occluded. You have changes in 1 AVL and V5, V6. These are the 4 leads in which you have problem in if it is in the circumflex. But circumflex is again a confusing artery. Sometimes LAD is always the largest artery, but the second and the third artery, they share sometimes. LCX is sometimes larger than the RCA. RCA is sometimes larger than the circumflex. If LCX is larger than the RCA, if LCX is occluded, it not only has ST elevation in lead 1, AVL, V5, V6, but also in 2, 3 AVF. Okay. If RCA is larger, then LCX becomes smaller. So it has ST elevation only in lead 1, AVL, V5, V6. So that is LCX. Then third artery is RCA, right coronary artery. Usually right coronary artery infarct is a slightly complicated infarct. Many times what people tell in undergraduate is, no, RCA inferior wall MI, no, it is a very dangerous MI, because RCA supplies the most important part of the heart. 1, it supplies the right ventricle. 1, 2, inferior wall of the heart, posterior wall of the heart, and most importantly AV node. The whole electrical apparatus of the heart is supplied by the RCA. So the infarction, LAD infarction, the muscle becomes weak. Okay, but RCA infarction, the muscle doesn't become much weak, because the amount of muscle supply is less, but the electrical supply is gone, because AV node is from the RCA. So RCA infarction is important. Commonly RCA infarction, ST elevation you have in 2, 3 AVF. Like what madam said, 2, 3 AVF, RCA infarction. But sometimes RCA infarctions can be extremely docile. You may not have much changes. you will be surprised many RCA infarction, even the cardiologist have missed many of the RCA infarction. So RCA infarction is why this is important. Now RCA infarction is important more so because in RCA infarction, as she rightly said, there are reciprocal changes in V1, V2. Reciprocal changes in ECG is very important, not in anterior MI, but in inferior MI. Because in inferior MI, RCA infarction, if you have V1, V2, V3 ST depression, that means posterior MI is taking place. Backside la ECG, V9, V10, if you keep the ECG lead, you will have ST elevation. So that is shown as ST depression in V1, V2, V3. That shows the RCA is super dominant. It's a huge RCA. On top of that, RV, RV4, RV5, right-sided chest leads nu solluvom. Always inferior wall MI, RCA, right-side chest leads you have to do because that is important for RV infarction. Because why this is important? Because RCA supplies so many territories compared to what we know from undergraduate days. It supplies the posterior wall, it supplies the inferior wall, it supplies the AV node, it supplies the right ventricle. So each place needs the electrode to be placed that way. So RV irundaduna, why this is important is because in an MI what we do, patient comes, patient has MI, you suddenly start giving diuretics. In a RV MI, we should never give diuretics. You should give a lot of fluids. So that simple thing can be, you don't need an echo, you don't need an angiogram, you don't need anything but V4R lead, one simple lead. If ST elevation is there in V4R with an inferior wall MI, that man or a woman needs a lot of fluids because you need to pump up the RV filling pressures. Compared to a LV, left ventricular MI, where anterior wall MI, where you need to restrict fluids. So you need to treat based on a simple ECG, not based on echo or some complicated things. So that is important with localizing the MI. Now after the lysis in that particular case, what happens? It settles. So infarct pattern initially starts with ST elevation. Sometimes you will be surprised, tall T wave is the first change in an infarction. Tall T wave. You see a tall T wave, that is the earliest sign of infarction is a tall T wave. Then you have ST elevation. Once you treat the patient with a lysis or primary angioplasty, then ST elevation settles like this. See how nicely it has settled? You have a Q wave and a T inversion. So when you have a Q wave, ST settled, T inversion, that means the muscle is now peaceful. That means the revascularization is done, blood is got back to the muscle, now it is breathing in peace. So this is a good sign of revascularization. Coming to the case 2, 60 years, male, diabetic, chest discomfort now for 12 hours. So time window out. So usually the time window we quote today is 3 to 6 hours. 3 is the best because within 3 hours, thrombolysis and primary PCI are equal. In fact, I would like to thrombolyze many of my patients. Whereas after 3 hours, with every passing hour, thrombolysis loses its efficacy and primary PCI becomes the better strategy. So 12 hours, time window missed, late presentation. So what is this MI? Anterior wall MI. So it's an extensive anterior wall MI, V2, V3, V4, V5, V6. Extensive anterior wall, you have some reciprocal changes here. Extensive anterior wall, late presentation. How do you treat this patient? Straight away goes for a cath lab. You have an LAD which is completely blocked and the LAD is open, patient does well. And once the LAD is open, you see the ECG. How nice the ECG is. Again, you can see the R wave is preserved. That is the beauty. So in spite of him coming late, one sign when you know that you have done a good job, whether with lysis or with primary PCI, is when you have a good R wave. When you have a good R wave, that means the muscle is still living. When you have a QS, sometimes plus minus 50-50, it may be living, it may not be fully living. Whereas when you have a good R wave like this, that means 100% in 3 months time, he is going to get back his LV function. Case 3, a 69-year-old male, dyspnea, chest discomfort, PND, 6 hours duration. What do you see in this ECG? Any takers? Dyspnea, chest discomfort, standard anginal pain, ECG, showing some ST depression, V4, V5, V6, 1 AVL, there is some depression in lead 2, there is slight up-notching of the AVR, okay. In fact, during my discussion about the leads, I forgot to tell you one important thing. AVR should always be negative. That is very, very important. In a normal ECG, if you see a AVR which is positive, that means the nurse has switched the leads. Please make a note because I forgot to tell you that. AVR negative, always negative, negative. AVR should always be negative. If it is positive, that means check the nurse. she must have switched the leads. They would have switched it. So AVR is very important, always negative. So there are some STT changes. We call it sometimes non-specific, sometimes specific. So how do you go about this case? This is a difficult case. The previous two are easy cases, because the previous two, the diagnosis is on your face. There is no marks to get you the case. What next? Yes, you have to do something known as a troponin. It is negative. What next? Echo. That is a regional valve. So I always advise the practitioners to do a troponin, and also, if possible, get a quick echo done if possible, because in my experience, in all our experience, many times ECG fools, or rather sometimes the initial phases of ischemia, ECG doesn't pick up much. So you need a troponin to bail you out. Sometimes you need an echo to bail you out. So once you do an echo, and there is regionals in the echo that we can find out. Supposing you don't have an echo, always make it a point to repeat an ECG. Very, very important. Don't go by one ECG. If you have a doubt, it is like, in intensive care, there is always a dictum. If you think about intubation, intubate the patient. Like that. So if you have a doubt, repeat an ECG after 6 hours. Repeat an ECG. See the ECG after 6 hours. The T has inverted. See, there is a T inversion, T inversion, T inversion, and that is a sign of ischemia. So what are the changes in angina? So angina, first important, the ECG can be normal. That is the first thing. Previously we spoke about infarction. Infarction is the vessel is totally gone, totally occluded. Whereas in ischemia or angina, where there is some flow, sometimes ECG can be deceptive. So the ECG can be normal, or you can have something known as a peaked T wave, flattened T wave, inverted T wave, ST depression with T inversion, ST depression with an upright T wave. All permutation combination possible. So you need to look closer into the ECG to know whether you are diagnosing it right or wrong. And whenever you have a chest pain, this is the working algorithm of ACC-AHA today. Chest pain, suspicion vandachinale, ECG. ST elevation, no problem. ST elevation MI goes for a primary PCI or a lysis. If no abnormality, very common, almost 50% of chest pains, cardiac pains, I'm not talking about non-cardiac pains, ECG may not have abnormalities to begin with. So either you repeat ECG after 6 hours, or repeat a troponin. So initial troponin is a must. So if it is negative, repeat troponin after 6 hours. Because you need 2 or 3 investigations. See, ECG normal, baseline troponin. Baseline troponin positive, okay, you know that it is ACS high risk. Then he goes to a ACS treatment. If it is negative, what do? You tell the patient, either you retain the patient in the casualty, or you tell him to at least go home, come back after 6 hours, take an ECG, at least do that. But please understand one simple thing, we forget one thing in our busy schedule. Listen to the patient. Patient will give you the diagnosis. Most of the times, you please ask the patient the correct questions. Anginal pain is a classic. You cannot miss most of the anginal pain. It's like your handwriting. It's like your signature. You cannot miss it, and most of the times we'll be right when we diagnose an anginal pain. So always tell the patient to come back after 6 hours. After 6 hours, get again a troponin done. If it is negative, low risk. ECG normal, second ECG negative. The second ECG shows significant changes, or troponin becomes positive after 6 hours. He is a high risk NSTEMI candidate or a ACS candidate, goes in for a invasive treatment with angiography. So we need to repeat ECGs after 6 hours to know what is going on, and please pay attention to the symptoms of the patient. Case 4, chest discomfort on exertion since 1 week. ECG, anything? Essentially normal ECG, nothing much in the ECG. What next? Chest pain on exertion since 1 week. What do you do next? Perfect. I think we have. So somebody said angiography. We have intervention cardiologists, everybody here. So troponin negative, again do a troponin. Any short duration pain, do a troponin. If the same guy had said I have chest pain on walking for 1 year, then no need of troponin. Short duration, always do a troponin. Echo, always do an echo. Normal. What next? Do a treadmill. This patient needs a treadmill. See the treadmill? Second stage of treadmill, strongly positive. You can see all these ST depression, 3 millimeter ST depression, V2, V3, V4, V5, almost all the leads, ST elevation AVR. Very, very important, ST elevation in AVR. So this patient, 1 week of chest pain on exertion, strongly positive treadmill, goes in for an angiogram. He has a triple vessel disease treated, and then he is sent home. Case 5. So why I am telling this is because all these are routine day-to-day bread butter cases, wherein no, these patients can come to you tomorrow. We should not miss them. Fifth case, tooth pain. Common reason. Many times they go to the dentist. I've seen patients having a tooth pulled out, but still pain still persists and then they come to us. So 83 years, tooth pain, jaw pain since one day. Because we always tell, from the jaw to the umbilicus, you can have angina. But don't miss cholecystitis. Don't miss pancreatitis. So those are also important DDs. But anginal pain can be from jaw to the umbilicus. This is a very non-specific ECG. You don't get any significant changes, some non-specific T-wave changes here, nothing much. But again, the value of doing a troponin elevated. CAG, look at the critical disease here, very tight LAD disease, treated with angioplasty, goes on. So, in just any chest pain syndrome, always keep it in mind, serial ECGs if the first ECG is normal. Serial troponins, very important. Get an echo done if possible. Effort angina, do a treadmill. Because many times I've seen effort angina, echo done, ECG done, lipid profile, TSH, nowadays all sorts of other markers like coenzyme, the CRP levels, etc. But a treadmill is not done. Have a low threshold for doing a stress test. That is the investigation many times in stable angina, which is going to give you the diagnosis. Now, coming to the next part, which is arrhythmia. Whenever you feel bored, you can stop me. Case 6, 38 years, standard IT guy, OMR, asymptomatic, underwent master checkup. அவங்களுக்கு தனியா பிரைஸ் கொடுக்கணும். This is a classical case which comes to you on a daily basis. This is a first degree AV block. Why do you say first degree AV block? PR prolongation. It is not only that, the PR is prolonged, which means the upper limit of PR is 5 small squares, which is 200 milliseconds, 0.2 second. So this is more than 5 small squares. But why first degree? Because every P is wedded followed by a QRS. There is no drop. So in the P, QRS, P, QRS, P, QRS, P, QRS, nothing is dropped. There is no P which is not followed by QRS. That is why this is a first degree AV block. First degree AV blocks most of the times are innocent. Most of the times are innocent. Sometimes drug induced. So you check out the drugs and then you do a Holter. Very important. Do a Holter. 24 hours. No significant increase in AV conduction or increase in AV block, medical management. So this patient is a first degree AV block, medical management. The next patient, case 7, 58 years male. Yeah. Pardon me? No. When I said medical management, reassurance send him. Sorry. Reassurance send him. So case 7, 58 years male, known case of diabetic, 1 episode of lightheadedness while driving a two-wheeler. Very common again, lightheadedness while driving a two-wheeler. What do you see? Anybody wants to take it? Yeah, good. So this is again, what we need to closely observe is, you have a P wave, QRS, P wave, QRS, P wave, QRS, P wave, QRS, P wave, no QRS. Again P, QRS, P, QRS, P, QRS, P, QRS, P wave, no QRS. So every P is followed by QRS, but then there is a dropped beat. So this is second degree AV block. In second degree there are 2 types, type 1, type 2, Mobitz type 1, Mobitz type 2. There are 2. How do you differentiate? PR interval you have to see. If there is a variation in PR interval, it is Mobitz type 1. So if you see the PR here, it is normal, slightly prolonged, more prolonged, drop. It is called progressive prolongation of PR interval followed by a dropped beat. So in Mobitz type 1 second degree, you have progressive prolongation followed by a dropped beat. If 24-hour ECG Holter shows only this and nothing else, then it is less life-threatening. But most of the patients will be asymptomatic. But if somebody has symptoms of lightheadedness with this ECG, you need to look deep. What do you have to do? Do a 48-hour Holter or a prolonged Holter. We can even do 1 week Holter. You have Mobitz type 1 on the left side always in the first day, but when the second day, third day comes, you see there is a P wave drop, PP drop, PP drop. So the PR interval remains constant and then there is a drop. So there is no prolongation of the PR interval. So without prolongation of the PR interval, if there is a drop, that means it is Mobitz type 2 second degree AV block, which is sinister, which is a dangerous condition, because this is a forerunner for complete heart block. So anytime these people can go in for a complete heart block, or who knows, if you do this for another 10 days, there may be a complete heart block. Many times ECG is only that second finding. So it is not something like, no, you cannot keep on repeating ECG. So maximum you can do a Holter for 7 days. But beyond that, on the 8th day, if he gets a complete heart block, we cannot help it. So this is sinister. So Mobitz type 1, most of the times they are safe. Type 2 is sinister. That is why he is having symptom. This patient needs a pacemaker. Simple. 75-year-old male, recurrent fall in last 5 days. Diagnosis simple. This is a complete heart block. Complete. So we had a type 1st degree, 2nd degree. This is 3rd degree. Why 3rd degree? Because there is no relationship between the P wave and the QRS. There is no wedding. The P wave is beating separately. The QRS is beating separately. The QRS is at a, this is a QRS here, this is a QRS here, this is a QRS 30 beats per minute, whereas P wave is marching separately. This is a complete heart block. This is the extreme form of heart block which needs a pacemaker. This is a pacing rhythm, pacing done. Now then you have to know about LBBB and RBBB, left bundle branch block. You saw the conduction system from bundle of His, it breaks into right bundle, left bundle. When the left bundle conduction is gone due to old age, you get this ECG. That means the electrical activity is conducting, everything is going from bundle of His through the right bundle to the entire heart. So it is not separating equally. So this is a left bundle branch block where you have a RSR dash pattern, rabbit ears, R, S and R dash pattern in lead 1, P5, V6 and broad QRS. This is a left bundle branch block. Left bundle branch block, if you see in any of the ECGs, routine master checkup or anything, you need to advise further evaluation, because this can be a sign of underlying heart disease, muscle disease, cardiomyopathies, ischemic heart disease, so on and so forth. Whereas right bundle branch block, if the right bundle is gone, most of the times it is innocent. Most of the times from young age you may see normal people going around with a right bundle. So right bundle is same rabbit ear, RSR dash, the same rabbit ear in V1 and V2 instead of 1 and V6. So it is the same rabbit ear in lead V1 and V2, which is a more innocent condition. Most of the time, 95% it is innocent. Case 9, recurrent palpitation typical of SVT, 40-year-old female. What is this? Huh? We have one KP Mishra here, I can only tell you that. Madam, your good name, madam? Huh? இப்படி மாட்டி விட்டீங்களா என்ன? இப்படி மாட்டி விட்டீங்களா என்ன? No, I have to stop the talk. Or you should come here. Anyway, I am so glad, madam. So this is, as madam said, is a WPW syndrome. Because I am just taking up only common things within the span of time. Why WPW is because recurrent palpitation, when you see the ECG, this ECG can be missed almost by 9 out of 10 people who see the ECG. You just see the ECG, somebody may say LVH. Okay, done. No. Look deep. You have a PR interval which is very, very short, extremely short, less than 3 small squares. PR interval which is very, very short. And you have a QRS, the upslope, can you see there is a slur? There is a slur in the upslope of the QRS. So slur in the upslope of the QRS with a very short PR interval, that means there is an accessory pathway. There is an accessory pathway. This patient, the conduction is not only through the SA node, AV node, Purkinje, right bundle, left bundle like that. There is an accessory pathway which is also contributing to the ECG, which means at any point of time, that accessory pathway can take over and produce palpitation and SVT. So this is an important ECG, because many times I was in railways before. In railways, most of the so-called the loco pilots will be debarred. Once you see this ECG, they'll be debarred. You correct this and come, because these are important things where in piloting and both in aircraft as well as in railways, because this is an ECG which has to be corrected with a radio frequency ablation. Once you do a radio frequency ablation of the pathway, the ECG becomes normal like this. This is a normal ECG after correcting the pathway. Next patient. This is a common problem which we face. Even WPW syndrome, what madam said, is uncommon, but this is very, very common. This is a 35-year-old palpitation with sweating. SVT. So I will just go forward to the next algorithm. This is a very important algorithm. Of course, borrowed from the great man, Dr. Mishra. Anything in ECG is borrowed from him. So if you have any tachycardia, first go into the QRS duration. Is it a narrow QRS tachycardia or a broad QRS tachycardia? Narrow or broad. That is the first thing which you need to do. Once you have a narrow complex tachycardia, then you see whether it is a regular tachycardia or an irregular tachycardia. Same, if it is a wide complex, see whether it is a regular or an irregular tachycardia. Okay. So now we go back to this ECG. See this algorithm. So this is a tachycardia. The rate is almost 220. It is first whether it is a narrow or a broad. It is a narrow complex tachycardia. So narrow QRS tachycardia. Regular or irregular? Regular. So narrow QRS, regular tachycardia. What are the differential diagnosis? Simple. So you have a narrow complex, regular tachycardia. Then you come to the slightly more complex part. P wave is present or absent. In that ECG, the P wave was absent, so it is AVNRT. P wave, if it is present, the commonest narrow QRS regular tachycardia is actually sinus tachycardia. Sometimes you can have AVNRT, focal atrial tachycardia, etc., etc. But the gist of it is always look for QRS duration, narrow, wide, regular, irregular, and go about. Now, why this is important for you is because if you have a tachycardia, I'll go to the next slide. If you have a tachycardia like this, what will you do? This is your common bread and butter. This is a tachycardia, yes, 120, okay? Narrow QRS or broad QRS? Narrow QRS, regular or irregular? Irregular. So, irregular narrow QRS tachycardia is equal to atrial fibrillation. So, this is a tachycardia which you see day in and day out. The commonest tachycardia leading to strokes. 80% of ischemic strokes in our country is due to this. If you please go, in fact, when we started doing Holters, we did a trial on doing Holters in ischemic strokes. Almost 80% of ischemic strokes had some form of AF, paroxysmal or persistent AF in their ECGs. So this is why this is important for you. You will be facing tachycardia, QRS, narrow, irregular AF almost every day in your practice. You need to identify them. Whereas the other form of tachycardia are quite rare in your practice, which is wide complex, regular is VT. Wide complex, regular is VT. Wide complex, irregular is AF with aberrancy, AF with WPW. So many complex things are there. But the common thing which you will see in daily practice is these two, regular, irregular, narrow complex, QRS duration, tachycardia. This is important. Even if you have a AF, in somebody at 50 years, please do a Holter. Because you don't know, the tachycardia may not be only that. There may be a VT also along with it. You can see all these things are AF, but suddenly you get a VT. So you need to be careful that you should not miss out on other forms of tachycardia which are there in tachycardias which are seen by you. Now this is important again for you. Extremely important. 50 years male with diabetes presents to the OPD with palpitation, shortness of breath since 3 days, walks in with an appointment. ECG. It's a ventricular tachycardia. So please understand, this is again Dr. KP Mishra. A VT patient can walk into your OPD, sit in next to you and say, hello, how are you? Don't think a VT patient should come only to the casualty as an emergency. VT guy can come walking to your OPD. which is very important. That is the difference between VT and VF. Ventricular tachycardia and ventricular fibrillation, the difference is, in ventricular fibrillation, he will be dying. That is what is spoken to us or taught to us in undergraduate. But VT, they may not be dying. They may not just be coming to you, walking and talking to you, because the rate is slower. The rate in ventricular tachycardia is usually 240, 250. SVT rate 220, 230. So they will be able to tolerate. But suddenly this will break into VF and they die. So this is again important, because the reason for this could be an MI. So a guy with this ECG, ventricular tachycardia, again why ventricular tachycardia? Tachycardia, broad QRS, regular, VT, can come walking to you. That is the message in this ECG. How to treat? Admit the patient first, then ideal will be defibrillate. Give IV sedation, cardiovert the patient. This is 40-year smoker brought to ER in unconscious state. Unconscious state. This is not my ECG, or rather I didn't take this ECG, because it's a VF. It's a VF, correct. It's a VF because you have an inferior wall MI. Can you see the ECG here? You have ST elevation in lead 3, lead AVF, and then suddenly there is a VF. So this is a classical VF in an inferior wall MI. A patient has to be shocked. So what is the difference between VT and VF? In VT you have structured morphology, broad QRS, whereas in VF it is chaotic and fibrillatory waves. It is not a structured morphology, it is chaotic and fibrillatory waves. How to manage? Cardioversion immediately. Case 14, 45 years, cough, shortness of breath with sharp pain in chest since 2 days. Common in general practice. Very common in general practice. Patient comes to us, chest pain sir, pomatengudu sir, romba valikkudu sir, pleuropericardial inflammation, very common, and sometimes this ECG can look like an MI also. How to differentiate is the clue. This is again a ST elevation but concave upwards. ST elevation in injury infarction is convex upwards, whereas this is concave upwards ST elevation, and you have the PR depression in most leads. PR depression in most leads, and the classical pain on deep inspiration, which is classical of pleurisy or even pericardium. Even the pericardium pain exacerbates on deep inspiration, and you have to make him lie down on the recumbent position and auscultate for a pericardial rub. You may get a pericardial rub. So this is a classical pericarditis, and most important finding in this ECG is the ST elevation is not localized to one lead, which is very important. Pericarditis ST elevation will be in all the leads. See, in lead 2 irukku, lead 1 irukku, lead V2, V3, V4, so it is not localized to one particular artery territory. So these are the different ways by which you differentiate a infarction versus a pericarditis. Another 5 minutes I'll finish. 55-year-old, obese, hypertensive, chest pain, sweating, acute dyspnea since 6 hours, referred as myocardial infarction. BP 70 query, saturation 75%. History of metatarsal fracture 10 days ago. What is this ECG? What is the diagnosis? Correct. S1, Q3, T3, pulmonary embolism. Any patient who is bedridden, fracture, underwent any surgery, long-term bedridden cancer patient, whenever they have acute dyspnea, always think of pulmonary embolism. Again, 100 rupee, one piece of paper is giving you the diagnosis, not complex investigation. One important thing in pulmonary embolism in ECG is always 100% of times there is tachycardia. If the heart rate is normal, it cannot be pulmonary embolism. That is rule number 1. So there is tachycardia. 1. 2. Always look for a right axis deviation, because when you have a pulmonary embolism, a large thrombus which is lodged into the pulmonary artery, the right side enlarges. Right artery, right atrium, right ventricle enlarges. So the whole axis shifts to the right. So right axis deviation is lead 1, lead AVF looking towards each other. So right axis deviation. Sometimes you have a strain pattern, RV strain pattern, T inversion V1 which is there, sometimes V2 also, which is not there in this case. But the classic is S1, RS, S1, Q3, there is a Q wave in lead 3, T3, the T is not very much clear here, but S1, Q, T is here, there is a T wave, T inversion is here. So T inversion in lead 3, Q wave in lead 3, and S wave in lead 1 with right axis deviation, tachycardia, acute dyspnea is equal to pulmonary embolism. This is pulmonary embolism. You cannot miss this. In this patient, you have to treat for pulmonary embolism. You have to do an echo, immediate echo. If you do the echo, what do you see? This is the thrombus. Can you see the thrombus jumping? Thrombus in the right ventricle, right atrium. This is the right ventricle, right atrium, right ventricle, right atrium are enlarged. Thrombus is jumping right from right ventricle. The thrombus is going into the pulmonary artery. Patient required immediate thrombolysis. Patient survived and went home. So this is an immediate diagnosis. It has to be done. You don't have to wait. See, this case, you cannot shift the patient for a pulmonary angiogram, CT pulmonary angiogram. There won't be time. 70 query BP. You have to diagnose at the bedside, put a catheter, neckline, central line, and thrombolyze the patient. Otherwise, the patient is going to die in few minutes. Case 16, 45 years, collapsed while playing cricket. Rushed to emergency room Sunday morning. Return of spontaneous circulation after 5 minutes of CPR. Intubated. What is this ECG? So, collapsed while playing cricket, rushed to ER, CPR, and then this is the ECG. What could it be? Collapsed, rushed, and then this is the ECG. Sometimes intracranial pressures, you have to be very, very careful. Many times subarachnoid hemorrhages can mimic as infarctions. So somebody, youngster, collapsing and then taking time to recover, never rush for a diagnosis. Patient is intubated, never rush for a diagnosis, because you need to know that there are other differential diagnoses for ECGs which are very similar to infarction or ischemia. Because this patient with such a global strain in a young age cannot be explained by ischemia. Global strain, all the ECGs show, all the leads show ST depression, cannot be explained by ischemia. It has to be something else. So do a CT brain, because he has collapsed. Do a CT brain. CT brain, these bizarre inverted T waves, cerebral T waves, where the T waves, ST depression are global in all the leads. CT scan confirmed a large subarachnoid hemorrhage, and we had alerted the cath lab. We aborted the alert, and then patient had to be treated for a neuro emergency. So we need to keep in mind all the other diagnoses also, especially in young patients who present with acute emergencies. Again, a 40-year-old, Sunday morning, marathon session, collapsed, brought to ER. Conscious now, conscious patient brought to ER, quadriplegia, electrolyte imbalance. Please keep it in mind. ECG is the first best tool for diagnosing electrolyte imbalance. And this is a classic hypokalemia. Classic hypokalemia, where you have standard U waves here, you have a QT which is prolonged, you have mild STT sagging, ST sagging. This is a classical hypokalemic changes. Why I am telling is you have to keep it in mind all these when you look into the patient. And hypokalemia can cause torsades like this, because if you don't treat these patients with potassium, IV potassium, because quadriplegia is a sign of hypokalemia. Most patients after a vigorous training, they collapse. Most of the gym deaths, in fact one of the gym deaths recently was hypokalemia. So many times they don't hydrate themselves, they just go on pumping iron and they collapse, and most of them are due to hypokalemia. Hypokalemia, as somebody said, can trigger what is known as a very fatal ventricular fibrillation, which is a torsades. Patient die on the spot unless you defibrillate or pace them. And I think this is the last case or last but one case. 75 years, living alone. Again, a very important teaching case for you. Living alone, recurrent syncope, diabetic, elderly person. ECG like this, recurrent syncope. When I said hypokalemia previously, this is hyperkalemia. Tall T waves, tall T. If you find a tall peaked T wave, broad bizarre QRS, prolonged PR, this is hyperkalemia. Potassium will be sky high. And most important old age problem is polypharmacy. Most problematic issue is polypharmacy in old age. If you see this prescription, enalapril, olmesartan, aldactone, Lasix, whatnot, everything. And these patients will be having 2-3 prescriptions from 2-3 doctors. And they will not tell me what they are taking from another doctor. They will not tell him what he is taking from me. This is a common problem. If you take all those things out, they will be taking 2 different combinations of enalapril, 2 different combinations of olmesartan. ஒரு மக்கள் மருந்தகத்திலிருந்து ஒரு மாத்திரை சாப்பிடுவான் எல்லாம் இருக்கும். So ultimately this is the chaos what they produce. So this is hyperkalemia and it has to be treated with proper medication. This is the last case. One of my favorite cases. Unfortunately, we lost this patient. 38 years male, known hypertensive, not on medication. Chest pain radiating to the left arm and back associated with sweating since 3 days. ECG. Pardon me, sir? Yeah, there are subendocardial in anterior leads, but you have to look into the ECG in the inferior leads, sir. Inferior leads. There is ST elevation. There is ST elevation in the inferior lead. So anybody will think, okay, chalo, this is an inferior wall MI. So this is an inferior wall MI. Patient is 38, known case of hypertensive. Obviously, before we do anything in the cath lab, we do an echo. Echo, we need to do it properly. This is the aorta. This is the dissection flap. So this is a aortic type A aortic dissection, ascending aortic dissection, which is closing the right coronary artery. So this is a dissection, and the right coronary artery is coming from the false lumen, due to which there is a right coronary infarction. So the right coronary infarction is not the basic problem. The dissection is the basic problem, because it's an uncontrolled hypertension. There is a type A dissection, and patient presents with a chest pain, back pain, but the basic problem is a dissection. And this is the angiography. You see a dissection flap going up, and we operated on him, but he didn't survive the procedure because it's an extensive dissection. He was pulse query, BP query by the time we took him to the theatre. So we need to keep in mind all these differentials, and ultimately ECG is the savior in most of these patients. So ECG, my dear friends, colleagues, seniors, and my teachers, is a gold standard investigation. And even after 200 years from now, I think it is the big boss of cardiology, no doubt about it. Thank you, one and all. Thank you.
Now I request Dr. Ganesh to hand over the memento for Dr. Hariharan. Next, Dr. K.B. Mitra, I introduced in MMC in 1982. After that, you have given a very good, elaborate and informative lecture about the ECG. And nearly 3 days we conducted at MMC, completely seminar hall and over veranda, and it appeared so happy, many people. So you are very popular. Now please continue, and we will sponsor one day 3 hours session.
Sure.
So it will be useful for us. Any interaction from audience? Any question?
Usually, what's the baseline that if there will be a doubt? The baseline of the ECG, sir.
Pardon me, sir?
Baseline to see the ST segment.
No, usually the J point what I discussed is QRS when it ends and the ST segment starts. So when you see the standard ECG, 12-lead ECG, you always note that the left end of the ECG, when the rhythm strip in the bottom starts, that is the baseline. So you always follow the rest of the ECG from that beginning point. From the left end of the ECG, when the rhythm strip starts in the 12-lead ECG, and then go according to that, up and down. You can even look into the PR. The PR interval, அதையும் வந்து baseline வச்சுக்கலாம். அதை வச்சுக்கிட்டு அதையும் வச்சுக்கலாம். வச்சுக்கிட்டு you can see the STs. Because again the PR interval னு சொல்லக்கூடாது. PR segment. Because once the P wave ends and the QRS starts, that is again isoelectric point. You can keep that as the baseline and see the ST also. No problem.
Just give a differentiating point between the type 2 cardiac heart block. Mobitz type 1 and
type 2. Simple, sir. Mobitz type 1 PR interval keeps changing. It keeps usually prolonging. We call it Venki back. It keeps prolonging followed by a dropped. P doesn't follow by the QRS. Whereas in Mobitz type 2, the PR interval will be normal. So P QRS, the third P, no QRS. Then P QRS, then P, no QRS. But the PR will be normal. It won't vary. That is the difference. No, sir. In both, there will be a dropped beat. But there will be a progressive prolongation followed by a dropped beat. Here, the PR will remain constant and suddenly you will see a drop. That is the difference.
Thank you, Sundar.
Thank you, sir.
We will arrange one day.
Sure. Sure.
Thank you, Dr. Sundar. It's been wonderful because keeping the audience up to the last minute is the excellence of the presentation. And, very interesting session. We just reminded of Dr. K.B. Mishra's classes, no? After a long time we have seen that. And thank you very much, and we brought out everything detailed about it. The basic what is needed for the medical practitioners. The mark of our respect from the IMPI and Chennai Metro, IIM Chennai Metro. We bring this memento.
Yes.
Wish you all the
Thank
best.
you.
And I'd like to inform one glad thing. His mother and myself were Coimbatore Medical College. Then again with his father in MMC, I recollect this about 45 years ago nearly.
Just reminded another disciple of Dr. K. Mishra is Dr. Kailash. He was very famous for his classes in KMC, ECG classes. Thank you, sir.
Thank you, sir. Thank you.
I kept on hearing ECG class for 100 times.
So
audibly I got it.
No, it is the operating subject matter. Always must repeat.
Only flavor to add is taking some Sanskrit words here.
and lot of humor.
Thank you.
Thank you, sir.
Thank you.
Thank you.